Thank you very much, Scientific Committee, for including me in this program of the PG teaching, which year after year has been a very, very valuable program. And the postgraduates are, what are you expected, or what do you expect from us? The examiner and the examination are big expectations, right? But when you come to these courses, it is your expectation that we have to match. And ma'am did a wonderful job of detailing about the dystrophies, and I'm sure all of you have picked up so many pearls from this. Complications of cataract surgery. Now, how we go ahead with complications of cataract surgery, and what am I supposed to tell you, or what do you want to know during these 25 minutes that I have with you? So now cataract surgery is fast becoming the refractive surgery, and this is something that you would be hearing, but complications are always there, and it is best to know what the complications are, what to expect, not only as for your career and how to handle them, but also when the examiner comes to you and asks you a set of questions which dwells upon complications, you need to answer them. And how you handle your examiner is how you're going to pass in that examination. So let us go through a few questions, or a few questions that are commonly asked in complications of cataract surgery. So the complications of cataract surgery, nobody is going to ask you, your examiner is not going to ask you, enumerate the complications of cataract surgery, or even if he has asked you, it's just a thought. So once you start off with something like intraoperative complications and postoperative complications, he'll possibly stop you. Okay, fine. Let us go to something more specific. And if perhaps you are one whose number in the examination hall is a little low below, say your name starts with S or Y or K, you possibly will be asked certain questions that are not generally asked. And then it's a question related to anesthesia that you might be asked. What are the complications related to general anesthesia? This chart do go through, because once in a while your examiners will ask such a question. So do go through this chart and do remember what the causes of general anesthesia complications are. So what are the patients who require general anesthesia? And of course in cataract surgery, and it's of course children below 8 years, yes, this is not an exact figure. It can be 10 or 12, and even kids of 15 might require general anesthesia. And the other patients who do require it is mentally unstable patients. Now look at this fundus photograph. What do you make of it? Something has happened, some complication has happened, and it's a tessellated fundus. Any clues? So while we go through this, and we've got a lot of FAQs to discuss with you, so just raise your hands if you know the answer. So can I see a quick raise of hands, and I'm going to give you the answer very soon. Something, the dark spot related to a tessellated fundus, maybe a high myopia. So what has happened? It's a globe perforation that has happened. And how are you going to treat a globe perforation? So what are the patients who are more prone to globe perforations? And it is higher myopes, because they have higher longer axial lengths, and there is a chance that they might have a staphyloma as well. And it is seen with which block? It is obviously seen with the retrobulbar block, okay? So with the retrobulbar block, which is not being given very much these days, and the peribulbar block is what is commonly given, so this dreaded complication is much less. So how is a globe perforation diagnosed is another question that you might ask, and it is hypotony, poor red reflex. When the surgeon is looking through the microscope, the red reflex, possibly it is a NS2 cataract, and he's supposed to see a red reflex. Red reflex is not there. Why? Because vitreous hemorrhage has taken place. And how do you manage such a case? The case should be postponed. The break, if it is there, should be identified. and it has to be treated before the cataract surgery if it is treatable, barrage, cryopexy, or with vitrectomy if there is massive vitreous hemorrhage, and then only the cataract surgery can be done. However, there are certain times where the VR surgeon will get together with the anterior segment surgeon, and a cataract surgery with a vitrectomy and doing a laser around the break is also done. So look at this picture. What is it? How many of you know what this is about? Hands? Okay, fine. We understand that you know it. The eye is very tense, and what might have happened is a retrobulbar hemorrhage. So this is a very common picture of a retrobulbar hemorrhage, and how are you going to, again seen with retrobulbar injections, the accumulation of the blood in the retrobulbar space is because of a rupture of the vessel by a needle tip, and this is how you would diagnose a retrobulbar hemorrhage: proptosis, tightness of the lids, chemosis, subconjunctival hemorrhage which can be massive, ecchymosis, and raised intraocular pressure. How do you manage this situation? Again, the surgery has to be postponed, pressure bandage, and a case to be postponed by at least 1 week. Now look at this question, and just tell me if you would know the answer to this one. Which anesthetic agent was the first drug which was used in ocular anesthesia? And this was by Carl Koller. Now, the clue to this is, if this substance is found out, you know the answer? Fantastic, fantastic. Cocaine is the right answer. We'll go on to the next. Now, the incision-related complications are favorite questions which the examiners usually ask, because these are actual complications which might take place because of a premature entry, buttonholing of the incision, scleral disinsertion, and irregular incision. So these are all the incision-related complications. And how do you manage a premature entry? If an entry is premature, you can create another tunnel starting posteriorly. What about a buttonhole incision? You again create another tunnel in a deeper plane, and thereby you have a better incision. Or if it is a scleral disinsertion, or it's a very ragged incision, what you can do is you can go on to a different site and create the incision tunnel. Again, very specific to a phacoemulsification. Inadvertently, you have made a large incision, and a large incision means a wound leak. Or if it is a too tight incision and you're using phaco energy too much, then you have a wound burn. What about the iris-related complications? And the iris-related complications could be injury to the iris, iridodialysis, and iris prolapse. Now let us look at a few interesting questions here. What is the preferred technique of iridodialysis? Now, McConnell suture should be your first answer. If you want to give another answer, it can be fourth-throw suture. These things are coming up, but what you need to say is McConnell suture first. What is IFIS? IFIS is again a very, very common question that is asked, and because the complications for IFIS is very much there. This is intraoperative floppy iris syndrome. What is the triad of IFIS? What happens in IFIS clinically? Well, progressive pupillary constriction, the mobile undulating iris, and the iris prolapse, both from the main incision as well as from the side port incisions. Now, which medications increase the risk of IFIS? This is a very, very common question because IFIS is something that is very common today. It is the alpha-1 blockers for benign prostatic hypertension, tamsulosin, for example. So we'll skip this video and let us take on this question. Have any of you seen a ring like this? Identify this hexagonal ring and where is it used? Fantastic, fantastic. This inventor is not only an Indian, he is a very, very close friend of mine. It's the BX ring, and Dr. Suben Bhattacharya actually, he invented this wonderful innovation, and it can be used for small pupils. What are the capsular Rhexis complications? Again, very simple: small Rhexis, eccentric Rhexis, runaway Rhexis, Argentinian flag sign. All these are very common questions that are asked, and it is asked in the primary grade. So you need to say the right answers to this. And from this, your second question that the examiner is going to put is going to be asked. So what are the Rhexis related complications? Again, what is the ideal Rhexis is another question that is very frequently asked, and it is a Rhexis of 5 to 6 millimeters. Why? Because there has to be 360 degrees overlap of the intraocular lens. What does it prevent? And the overlap, what is it supposed to prevent? PCO, right. Very good. And what are the different ways in which a Rhexis is created? How do you do a Rhexis? Manual? Any other way? You can do it with the cystotome or the Utrata. Any other way? Quick answers, quick responses. Femto laser, another? Zepto. Fantastic. So you need to say all these, and if you have answered really well, then your next question set might go to femto laser or Zepto laser. What are the complications seen with a small Rhexis is a very, very interesting question, or a very common question. Again, intraoperative, the difficulty in removing the nuclear management. Really? Okay, 25 minutes, no?
Yeah, but then we started late.
Oh, I see. 25 minutes are not? Shall I?
Yeah, but then 11 o'clock.
Okay. So, fine.
Second, see, because second, anyway.
Okay. So, the Argentinian flag sign, this is a very important question again. This is because of the radial extension of the capsule Rhexis, because of a small nick and because of a raised intraocular pressure. It is seen in the intumescent lenses. And what is the management? You need to make it into a Rhexis as much as possible. If you can do off a phacoemulsification, but it is a little bit of a challenge. The safest answer would be to do an SICS and get the nucleus out without endangering the posterior capsule. Let us give you a quick, important question. What is a reverse Argentinian flag sign? Now, this has just been described, and it is because of excessive OVD and this OVD, overfill of the OVD in the anterior chamber, a non-intumescent or a normal cataract, the Rhexis can run out, and this is seen in the non-intumescent cataract. So posterior capsular rent, can I have 5 minutes?
Yeah,
okay, fine. So posterior capsular rent and vitreous prolapse, these are again very important FAQs. What type of cataract is most notorious with PCR? Posterior polar cataract is the right answer. Which step of the surgery is most notorious for PCR? The step of surgery. It is usually documented that it is the step in which you are doing the IA, the irrigation aspiration. Again, what are the steps to be followed for an anterior segment surgeon? If there is a PCR, you have to go with low parameters, lower the bottle height. You have to do dry aspiration. You have to do an anterior vitrectomy and an anterior vitrectomy assisted by tricot. This is very important, triamcinolone assisted anterior vitrectomy. If the PCC, if the posterior capsular rupture is small, you can convert it into a posterior capsular Rhexis, and thereby you can place a lens also in the bag, but otherwise you should always place the lens in the sulcus. And what intraocular lens can go into the sulcus? Single piece, multi-piece? Three-piece. Multi-piece lenses always in the sulcus, single piece never in the sulcus. And to close the wound on the table, the IO has to be done, and indirect ophthalmoscopy has to be done to see that no chunks of nuclear matter has fallen into. What is this little short video? What is this all about? What is this condition and what are we doing? So this is, you can see the dehiscence of a posterior polar cataract, and a femtolaser cataract surgery is being done, and you can see that the offset of the cylinder that is going to be extracted through the femtolaser is 700 to 800 microns, and that protects the posterior capsule and the dehiscence of the posterior capsule. So nucleus drop is another very important question that you need to answer. And the last beamer, and I'll wind up. So can any of you name this incision which is being created? This incision is being created from the limbus. The conjunctiva is intact. It is being created from the limbus. It is going half into the sclera. It is called the Hoffman's pocket. And it is a very important innovation, this Hoffman's pocket, where you do not disturb the upper conjunctiva, and a very neat incision is made. And I think I will, with the respect for time, I will stop with this. Thank you very much for your patient hearing. Thank you.